Hello everyone, the topic for today is pleural effusion. It is defined as the accumulation of fluid within the pleural cavity. It will occur when there is an excess of fluid formation, when the fluid is leaking via the parietal pleura, the visceral pleura, or through the peritoneal cavity via the diaphragm. It can also occur when there is an obstruction of removal of fluid via the lymphatics. The diagnostic approach to pleural effusion is very simple. You have to first go with a dedicated history and physical examination and confirm the diagnosis via investigations. So initially, if the patient complains with cough or dyspnea, you should think of pleural effusion that might be present in the patient. Also, pleuritic chest pain is a defining feature. In the investigation, remember that investigation of choice is chest ultrasound. You can also go with the lateral decubitus X-ray. You can also go with CT scan, which is definitive in nature. Once you have confirmed this diagnosis, the next step is to go with diagnostic thoracentesis to look for the etiology. In the initial step, you will measure pleural fluid protein and LDH value and see whether Light's criteria is satisfied or not. This criteria is referred to as Light's criteria. If Light's criteria is positive, it means you have to look for various exudative etiologies, which include various inflammatory causes and neoplastic etiologies. Or if Light's criteria is not satisfied, you should think of a CHF cirrhosis or nephrosis that might be present. Also, you look for peritoneal dialysis as an important cause in transurethral pleural effusions. You should note that Light's criteria is only correct 75% of the time, whereas in 25% of the cases, Light's criteria will not be correct. So, in this condition, if you're suspecting transurethral pleural effusion, go with measurement of serum to pleural fluid protein gradient. If this value is more than 3.1 gram per deciliter, rest assured this is a transurethral pleural effusion. Now, also, once you have confirmed that the pleural effusion, say it is exudative in nature, you have to go with a lot of investigations, which includes various biochemical, hematologic, cytologic, or microbiology studies, including but not limited to glucose, cytology, cell count obtainment, and culture gram staining. You can also look for pleural fluid markers for TB because it is one of the most common causes worldwide. So this includes adenosine D minus and interferon gamma levels in the pleural fluid. Remember the special cases of etiology where the glucose value is reduced. In these cases, suspect malignancy, bacterial infections, and various autoimmune disease like RA or SLE. Now, let us first discuss the various etiologies for pleural effusion. So, in transurethral pleural effusion, if the cause is CHF, just remember that it is the most common cause of pleural effusion overall. It is also the most common cause of transurethral pleural effusion. There are some important features that will help you guide that to diagnose pleural effusion due to CHF. This includes bilaterality or symmetric pleural effusion on both sides, and there should be no fever and pleuritic chest pain. If any of these features is absent, you should reconsider your diagnosis. Definitive diagnosis can be made by measuring NT-proBNP levels in the pleural fluid, which should be greater than 1500 picogram per ml. So in cirrhosis, generally there is a right-sided pleural effusion, just a point to note. After that, exudative etiologies are more common and they are more extensive. Let us go with discussing it one by one. Let us look at first infectious etiology. It can occur via various bacterial, viral, fungal, and infections. Also, parasitic infections can cause it, and tuberculosis is one important cause. If the pleural fluid analysis reveals eosinophils, think of parasitic causes, various drug-related etiologies, and post-CABG condition. So, drugs include nitrofurantoin, amiodarone, or bromocriptine, methotrexate. These are the important drugs to remember. In the infectious etiology, just remember two important conditions. One is parapneumonic effusion, and the other one is tuberculous pleuritis. So in tuberculous pleuritis, remember that it is the most common cause of exudative pleural effusion worldwide and in India, whereas parapneumonic effusion is the most common cause of pleural effusion in the West. It is generally secondary to bacterial pneumonias, to bronchiectasis or lung abscess. Whereas in tuberculous pleuritis, it is generally due to a hypersensitivity reaction. It can also be frank empyema. It is generally seen in primary tuberculosis, and pleural fluid analysis will reveal a low glucose along with lymphocytic infiltration, and the ADA levels are more than 40 international units per liter, and interferon gamma levels are more than 140 picogram per ml. Parapneumonic effusions, the treatment is therapeutic thoracentesis if the distance of separation between the chest wall and the lung is more than 10 mm. You should go with looking for various risk factors in this pleural fluid analysis. So if there is a loculated fluid collection, or pH is less than 7.2, glucose value is less than 60, or there is frank pus in the area, or it is related to an infection, then it means that you have to go with fibrinolytic administration, like tissue plasminogen activator or adenosine diamine or DNase enzyme in the pleural cavity. You can also go with surgical treatment like pleural abrasions. So These are the infectious etiologies. Next is looking at the immunologic etiologies. That includes RA, SLE, granulomatosis with polyangiitis, EGPA or sarcoidosis. Then we have malignancy. Malignancy is the second most common cause of exudative pleural effusion. The most common cause includes lung cancer, breast cancer, and lymphoma. If the cause is mesothelioma, generally there will be a history of asbestos exposure along with an increase in mesothelin 1. Pleural fluid analysis will reveal cytology that is positive for malignant cells, and glucose counts will be reduced because tumor cells will take up all the nutrition. Then chylothorax is secondary to iatrogenic trauma, generally seen during thoracic surgery. Pleural fluid will reveal milky fluid, and along with that the TG levels are elevated to more than 110 milligram per deciliter. In this condition, always suspect the presence of mediastinal tumor, and thus mediastinal CT is necessary. Definitive treatment is tube thoracostomy with octreotide administration, and if not responsive, you can go with surgery. You should always avoid prolonged tube thoracostomy in these patients because it will lead to malnutrition and immunodeficiency. There are various other miscellaneous causes for pleural effusion as well. Remember ovarian hyperstimulation syndrome. Along with that, Meek syndrome, in which there is characterized by a triad of benign ovarian tumors, along with that ascites and pleural effusion, all of which is reversible once the benign tumor is removed. In yellow nail syndrome, again there is a triad in which there are yellow nails along with lower limb lymphedema and pulmonary complications like pleural effusion and bronchiectasis. In gastrointestinal diseases, remember esophageal perforation or say pancreatitis. In these conditions, the pleural fluid amylase value is elevated, and pulmonary embolism is an underlooked cause for pleural effusion. So if the diagnosis remains obscure, you should think of pulmonary embolism as one of the important etiologies. So this is also given over here in this diagnostic algorithm. So this is all that is related to this chapter. Remember that there is one more extra condition that is related to pneumothorax that is presented in this chapter. I think you can read this on your own. I will just give you a brief idea. That is, it is divided into a spontaneous category and a traumatic category. In the spontaneous, it can either be primary, where there is no underlying lung lesion present, or it can be secondary, where an underlying lung disease is present. In primary diseases, a simple observation or needle aspiration will suffice, but in secondary cases, because the pulmonary reserve is reduced, pneumothorax can be life-threatening in these patients. So tube thoracostomy is mandatory. That's all. Do read the book. Thank you.